So the next is role of primary care in achieving elimination, and we have Mark Gillyon-Powell and Sannaa Raja speaking about this topic.
Thank you for asking us to cover primary care as well today. We firstly, apologies from our primary care clinical lead, Anisha Noonan, who works for us in the national team for one session a week, helping us really with the primary care elements of elimination. She's on leave this week, so she was really sorry that she couldn't make it. So we're going to try to cover what she would have said. And we've also got an input on the last slide of this from one of our GP champions talking about the role, so that you can maybe understand a bit more about some of the bits of work that we've been leading on. I'm not going to go over that again. You know, we've delivered an awful lot and we continue to try and do so. Did you want to briefly mention that?
Yeah, so we know obviously Mark and Ashley spoke earlier about now that we're moving towards the final phase of the elimination programme. This involves obviously identifying people with history of exposure to risk factors who might not know they're at risk, and those with a diagnosis who have not yet completed treatment. We've spoken about the other elimination initiatives, which you can see on the screen. So now we're just going to focus on the role that primary care plays in finding these people.
Yeah, just in relation to this diagram, it's something that I use sometimes when I'm working with, because I speak quite a bit at primary care conferences with GPs who might know nothing at all about Hep C. So really, this is just something called the commitment curve, and some of you might be familiar with it from other areas. But basically, on the sort of bottom left of the screen, as you look at it, you've got people who might be starting to show some degree of awareness of a condition or a subject. And right up on the sort of top right is people kind of feeling ownership and understanding and wanting to do something about a condition. This applies quite well to a lot of the GPs that we speak to. So a number of them might be up in that top right and actually be really engaged, be really interested in blood-borne viruses, interested in health inequalities, and really keen to do stuff. They're probably in the minority. From our experience of going and working with GPs, quite a lot of them are in that sort of bigger circle in the bottom left. So they're kind of aware of it. They've sort of heard of Hep C. Some of them think they might have vaccinated some of their patients for that. You know, it's just kind of a bit, they know that something's going on, but they're not quite sure what. And they're not quite sure what they do about it if a patient came in and asked. So, sorry, I'm moving about. I'll try and stay near the microphone. So we get varying, but people either having a little bit of awareness down to very limited awareness. And then right in the bottom left-hand corner, the little sort of grey circle, is people who just don't know anything about it at all. And these are clinicians that we've spoken to and said, can I talk to you about Hep C elimination? And the answer literally has been, what's Hep C? Maybe that's perfectly fine, because Hep C's tended to be something that's been looked after in secondary care mostly. And GPs are incredibly busy and have a huge range of competing priorities. But really one of the things that we want to try and do is move people from that kind of bottom left vague sense of awareness up to a position where they feel more confident about working with us around hepatitis C and hepatitis C elimination. Do you want to?
So we know, I was speaking to Stuart at lunch about it, about how much potential there is in primary care. So AXA data suggests that there may be as many as 50,000 patients with hepatitis C in the primary care sector, but the actual numbers are unknown. Primary care has the potential to reach a significant number of these patients that are untreated or undiagnosed. GPs have access to the wider general population. So Mark mentioned earlier that 62.3 million people are listed with a GP in England. They also have access to a whole medical record for patients. So this will allow them to assess potential risk, and they have a lifelong relationship with their patients, so they can engage, follow up, and care for them in a closer therapeutic relationship over a much longer time period. And the expertise of GPs is holistic care of patients with long-term conditions and multiple comorbidities. However, we also know that we've experienced ourselves that primary care faces a lot of challenges. As Mark mentioned, current awareness of hepatitis C is very low. General practice is overworked and under-resourced. There's competition for long-term conditions, some of which offer a high financial incentive. And we know that GPs have been slow to uptake PSI tool usage for these reasons. So what can we do in primary care? We believe there's a range of ways we can engage and support primary care in Hep C elimination. These are the pilots and programs that we are currently developing. They won't all be suitable for all primary care providers, but it provides a range of options that can be implemented according to local need. And in order to identify local need, we're currently working with UXA and commissioning service units to kind of use national data to allow us to identify hotspots of where that need is, so that we can direct our efforts in a more targeted way. One of the programs we are currently developing is the GP champion model, which I will speak more about. So in London so far, we have 20 GPs. The GP champions are funded by NHSC to work with their local ODN on the Hep C elimination for that area. London has 20, and they work to cover a specific London borough. So obviously there are gaps. Each ODN is taking a slightly different approach to how they utilise their GP champions. I know there's something that's not on the list here, which I did speak to Stuart about at lunch, and one of our GP champions, she's kind of looking at using the PSI tool and running it in her practice and other practices, and then when she identifies patients with low risk factors, she's asked for a URL code for the web testing portal specific to that kind of area, so patients will be sent a text message, and they can then access the web testing portal via that text message. And as Mark mentioned shortly, we'll see a video from Grace that she created in collaboration with Hep C later, just to talk about the work that she's doing in Lewisham as a champion and her plans to expand that work.
I'm just going to really briefly just nip back to the list of things, just because some of you might not have heard of some of them before. So people will probably be aware of the patient search identification tool that was developed as part of the strategic procurement between NHS England and MSD, which has been used variably across the country, but that also fed into the development of EMIS Pathway as a specific tool to help manage using the PSI tool. And that then also ties into what Sannaa was just saying about the web testing portal. So an example is Cheshire and Mersey ran a pilot with EMIS Pathway, identified in one practice 300 individuals with the patient search identification tool who had some risk factors associated with Hep C, and automated a link to the web testing portal for each of those 300 individuals. And literally within 2 weeks, we saw a spike in the number of orders that came from Cheshire and Mersey, because we could track that link. So all of these things kind of feed into each other. The issue around, Sannaa mentioned about us looking at hotspots, trying to look at data that might indicate higher levels of risk, so that we can target things like, we initially thought about a direct enhanced service with primary care, where we would basically pay every PCN a set amount of money, a primary care network, to run the tool. Based on the numbers of positives that we were getting back through the patient search identification tool as we'd used it, it would have worked out massively expensive, probably about £5 million a year over 3 years to run a DES would have just been unaffordable, and the return for the numbers of people we would have found would not have justified it. So one of the things we're doing is looking at data that's available to UKHSA and to the commissioning support units who handle a lot of the GP practice data to work out if they can run the tools on things like the PSI tool on commissioning support unit, primary care data, and even just come back to us and say, actually, in this practice or in this primary care network or in this ODN, we've identified this number of people with Hep C positive codes on the GP system, this number of people with these risk factors and this number of people with these risk factors. So we can then target things like saying, okay, we know that that area now needs a GP champion who can go in and start doing that work with that practice or that PCN. So we can kind of tie them all together in a way that we didn't really try to do before. We were just trying to work with willing GPs and persuade them that they could squeeze in a little bit more work when realistically they probably couldn't. So we're just getting a bit smarter really about how we target the resource and develop things like the GP champion who can provide that capacity that the rest of primary care doesn't necessarily have. So this is where we want to get to. We want to get to a position where we've got adoption and ownership of Hep C within primary care, where people feel like it's theirs and it's just the way they do things. Because again, once we've reached elimination, primary care is still going to be there. Yes, hepatology will still be there and drug treatment services will still be there and prison reception testing will be there. But actually out in the community, the kind of touchstone for the health system for most people is still going to be their primary care service, their GP, their pharmacist, their practice nurse. So trying to kind of get buy-in and engagement is really a key part of what we need to do to take the primary care work forward. And as Sannaa mentioned, there are potentially, maybe 50,000 people still within primary care somewhere who maybe haven't used drugs since the 80s, like a couple of the people who were found in Cheshire and Mersey when they were using the PSI tool through EMIS pathway. And those people might have had kids since then. So we need to kind of do that more general patient finding within the population to be able to find those people who aren't necessarily going to identify risk themselves. I don't know how to make this play. Do you know?
Yeah.
My name is Grace Tony, and I'm a GP and also the Hepatitis C GP champion in Lewisham, which is in South East London. And my main role is to drive the Hepatitis C elimination programme in primary care. With my secondary care colleagues, I helped to deliver an educational session, and that was working in conjunction with our local education and training hub. And we delivered the educational session to our local GPs, nurses, and healthcare assistants. And our next stage is to work with individual GP practices, and that is to identify patients who could be at risk of hepatitis C and offer them a test. Before we even start to increase hepatitis C testing in primary care, we need to make sure that GPs know what to do with a positive result. So one of the first things that I worked on was developing a clear and effective referral pathway from primary care to secondary care where patients will be treated. So we worked with the South East London Operational Delivery Network based at King's College Hospital, and they now have an email address, a central email address where all the GP referrals can go to. And there is a specific referral form for GPs where we have explained how to interpret the results and who to test. And then that referral form is emailed directly to the secondary care teams and they will contact the patient. So this means that we have we know that GPs know what to do patients know what to expect, and then they can start treatment as soon as possible. So I think there are two main groups that general practice should focus on. Firstly, it's people who might have injected drugs in the past but aren't currently injecting right now. And the second group is people who were born in countries of high prevalence of hepatitis C, but are now living in the UK. So both of these groups may have been exposed to hepatitis C when they were younger or many years ago, and they can be going undetected because they might not be developing symptoms for 20 to 30 years. There are obviously other groups that are at risk, and you can find more information on the Hep See You Later website. In primary care, in order to identify these groups, we need to be asking the right questions. And they can be awkward, but they are ultimately life-saving. And the Hep See You Later program is developing resources for patients that you can put in your GP surgeries, in your community settings. There is another group that is at risk of hepatitis C, but actually don't want to access their GP practice. And this could be for many reasons. Maybe they're embarrassed because they've known their GP for a long time, or simply they don't have time to come to the practice for a blood test. So the NHS has developed a self-testing portal that you can access online, and a hepatitis C test will be delivered straight to your door. So I've actually taken the test myself. It's really easy, and the package came to my door. It was very discreet, and I got my results within 2 days actually, and it says it can take up to 2 weeks, and it was really easy and really effective. So if you want to know more information about the self-testing portal, you can look on the Hep See You Later website. During my GP training, I spent 6 months in the HIV clinic and the sexual health clinics in Lewisham. And I particularly enjoyed the challenges really around HIV. And in particular, it was the misconceptions around HIV, and there's still a lot of stigma surrounding it, even though there is very effective treatment. And there are several misconceptions, not only in the general population, but also amongst healthcare professionals. And this spurred me on to become an HIV GP champion. And I have been doing this work for the last 4 years in Lewisham. And so what particularly interested me about hepatitis C is that it is quite similar to HIV because there is still a lot of stigma surrounding it. And so, this can be reduced with education and training. What's interesting is obviously with HIV, you can lead a very normal and healthy life. But with hepatitis C, you can actually go that extra step and you can cure it. So this is what sort of spurs me on to be this GP hepatitis C champion, because I really do believe that we can eliminate hepatitis C in England. I think one of the main challenges is that general practice is really overstretched. As a GP myself, I know the struggles that we're facing, and we are trying to manage patients with several comorbidities, and we have short appointment times, and we have a depleted workforce. So we really need to be careful not to overwhelm GPs with more requests. However, we are managing many conditions who are long-term, chronic, who don't have a cure. But with hepatitis C, there is a cure. So we really can eliminate this disease. And we have an easy test. We have now in Southeast London a straightforward pathway. And so patients can get treatment really quickly. So being able to be part of this national elimination program is really exciting. And, you know, we want to try and push hepatitis C to remain on the primary care agenda until we achieve elimination. And because we really want to make hepatitis C a disease of the past. So if you are interested in becoming a champion or want to know more, just contact someone from the Hep See You Later team, and we'll be in touch.
So I think you can probably imagine that me going into a primary care setting and saying, oh, you don't fancy just doing this extra bit of work for us, do you? Or even our secondary care colleagues going in and doing that, is a very different ask to a GP like Grace that we can target to a particular area and say, could you go in and work alongside people and do this work with them, or even do this work for them? It's a very different ask, and it gets a very different response to us just kind of saying, this is the elimination program, wouldn't you like to be involved? Grace and the other 19 London GP champions and the other GP champions that are cropping up now, or that we're starting to have discussions about in terms of funding them in other ODNs, because any ODN can do this. We will help you to identify GP champions. We have role descriptions. We have a peer network for those GP champions to engage with. It's been a real game changer, I think, in terms of our ability to link to primary care, and will certainly help us over the coming, hopefully, year 6 and 7 of the strategic procurement to get to those communities that we've missed so far. Is there anything else you would?
No, I think that's
Okay. Thank you.